One of the measures that you say will be compensated is the complexity of a patient. How do you measure that?
I'm going to ask Dr. Dosanjh, who deals with complexity of patients a lot, to talk about that because it's an important part of the agreement. But I think here's what I'd say, that there are ways, and we've been, I think as a system, trying to do this for a long time. Someone in my circumstance who has type 1 diabetes, I'm walking in with type 1 diabetes to every appointment if I go and see Dr. Dosanjh, and whatever's bothering me on the day, and whatever I need to see the doctor about on the day. And that adds to the complexity. It's a reason why people with chronic disease really need a full-time healthcare practitioner to support them and to understand when they walk in, so I don't have to explain, oh, I'm a type 1. Here's what's happening. They know because they have those results. We're seeing an increasing complexity of patients across the board. And so there are ways, and what you have is a detailed system of measuring complexity of patients. If you have, for example, a patient roster that's dramatically older or has a very significant group of people who have, say, mental health and substance abuse issues, by definition, you have to spend more time with those patients. But the overall patient population is also increasing in complexity, and this agreement reflects that. And so at different times, we may have significantly different needs of our healthcare system. We always need it, but at different times, those needs may be more intense for whatever reason. We're diagnosed with a chronic disease. Obviously, our whole maternity system is the requirements of that. As we're younger, we have different needs than if we get into our teenage years. So I think what you need and what we have is a flexible model that focuses on the needs of patients and allows doctors to focus on care. But there are lots of ways to measure complexity. We have them in the agreement, and I'll ask Dr. Dosanjh to speak a little bit about how she does it in her practice.
Thank you for the call. And just not to get too much into the details of the agreement, but the understanding that all healthcare systems around the world, especially primary care healthcare systems and the evaluation of them, and we've got in Canada, obviously all of our research and healthcare policy abilities to be able to look through either MSOC scores, which may be irrelevant to everyone listening and may not know the details of that. But really what you look at is exactly that. Some of that Minister Dix just spoke of is that time with the patient. What is the chronic condition or the disease, and how does that burden the patient, but also the needs of based on how many consultations they need or how much the time they take with you in your clinic office setting. And it's not necessarily just on aging, but we've known that many of our aging populations and our geriatric populations do have needs for more time, and the assessments in your office take a little bit longer. But also I could say that the opposite for some of our younger patient populations with complex, either they've got some conditions that require a lot more work and effort, or some of our BC cancer patients that need more time, and those are the issues and conditions that are systemically built, and assessment on a diagnosis code that physicians will input sometimes into their electronic medical record or to look at through the MSP billing guide, that there's an opportunity to look at those individual codes and the complex care required by that patient, or how many times that patient may have accessed the emergency room or the primary care setting, or require diagnostics or tests. And that's where we look at that data, and that's when we look at chronic complex patients. We're not saying everyone does deserve care and access to primary care, and that is our hope, is to build a foundation to really work into the preventative aspect, because right now we need to anchor all those patients that don't have a physician, but we also need to recognize our need for healthcare prevention and to focus on wellness and well-being of our patient populations, along with our public health experts and our people that are doing this work, especially in our pediatric populations, our mental health populations, and our female populations. And again, like Minister Dix has said, in our physician master agreement, we actually have embedded gender equity. And this is the first time we're seeing this. And hopefully even the fee-for-service schedule, we can modernize that payment schedule to reflect the needs of all patients. And that is what I'm saying, is building on healthcare equity. This is a milestone for that.